Welcome, everyone. We'll wait just a few seconds here to let everyone join, and then we'll begin. Okay, welcome to the Healthcare Lounge with Nelson Griswold. Today's topic is what I saw at the Revolution. Now I'll turn it over to Nelson.
Thanks, Kendall. Welcome. This has been building for a while since the passage of the one big beautiful bill and out of the Republican Congress. And then my time in Washington about a month ago, month and a half ago, for the invitation only MAHA Summit, which was very hush hush, closed to the media and a very elite exclusive group. I was delighted to be included, uh, and we'll talk about who was there and some of the things I heard and saw. But these two need to be taken together. We can't look at the one big beautiful bill, the legislation, without looking at what's going on in the MAHA movement, because MAHA is driving the health agenda of the Trump administration. So, what I saw at the revolution, this is about how policy and culture are reworking, rewriting employer-sponsored healthcare. It's going to be gradual. It's not going to be revolutionary, but we've got 4 years, 3 more years, basically, of this administration running the federal health uh, aspects of the government. And so even if Congress goes over to the other party in the midterms, doesn't really matter, because between executive orders coming out of the White House and Secretary of Health and Human Services, the commissioner of CMS, the director of the FDA, and the head of the National Institutes for Health are all MAHA aligned. So what is going on? Well, first of all, please understand this is not a political webinar. This is not commentary. This is all fact-based. This is what has been passed, what has been said, what I have heard, what I have read coming out of this administration. So two major signals we're talking about here coming out of DC. One of them is the one big beautiful bill and the aspects of that legislation that affect employer-sponsored health plans. The other signal, this massive signal, was the 2025 MAHA Summit in Washington at the, I forget the name of the hotel, Waldorf Astoria, a beautiful Waldorf Astoria hotel. Um, Secret Service had to go through Secret Service clearance to get there because of the high-ranking administration officials who were there. But understand, we're talking about strategy here for executives. This is not commentary. Both of these signals impact employer health care, but more importantly, it's starting to shift more responsibility downstream to the employers running these health plans. And this is going to be huge for them. So the two signals, the one big beautiful bill act, which of course came out of Congress and signed by the president, but implementing the administration's preferred strategies around healthcare, and then the MAHA Summit in Washington. So here's the big picture. Healthcare is moving from the HR department and considered an HR issue a benefit to an enterprise risk. Now, frankly, it's always been an enterprise risk, but this administration is pushing the mindset in that direction. the actions they're taking, the language they're using, all of this point to a a a shift in healthcare back onto the employer, which frankly, the employer has not taken responsibility for healthcare. They pay the bill, but we know that executives are all asleep at the wheel because of healthcare's big lie. That healthcare, you can't control the cost of healthcare. So every executive in the country pretty much says, well, if I can't control it, let me give operations to a line manager in HR, and I'm going to focus on things I can affect, things I can control. Well, many of you will know that yes, you can control the cost of healthcare. That's why it's healthcare's big lie. Of course, you can control the cost of healthcare. Next gen advisors are doing it every day. The employers they're working with are doing it every day. But most employers believe they don't have control. What this administration is saying is you're going to have to take control because no help is coming from Washington in terms of cost. And that's not that's not the administration saying that. That's just a fact of life around healthcare when there are 4 to 6, depends on how you measure it, 4 to 6 lobbyists on the healthcare side for every member of Congress. Congress will not address the cost of healthcare. Not going to happen. So we all know that healthcare is a top 3 line item in every company's budget, just about. If it's not 2 or 3, it's 4. And the important thing here is to understand and remember that the health of the employees directly impacts productivity, and the quality of the health plan affects retention. If it's a crummy health plan, if the employee doesn't feel like they're getting things special, there's no reason to stick around. Not for the health plan. You've got a Buca health plan, well, so does every other employer in town. So that's not a retention tool. That's table stakes. You got to throw your chip out into the middle of the table to play the game, but it's not a competitive edge. It does not affect retention or recruitment. That's a huge, huge myth. Yeah, we're going to offer Blue Cross because, well, everybody offers Blue Cross. If it's a Blue Cross town, everybody offers Blue Cross. The other point is the policies that are coming out of Washington are reinforcing the current system. They have said, we are not going to try, as some policy experts have suggested. In fact, on the conservative side, coming out of the Cato Institute and the Heritage Foundation, there has been a push to separate healthcare from the employer. In other words, make the plans portable and make the plans belong to the employee. Well, all that's going to do is push every American into the Obamacare exchanges, which is not going to help on quality at all. It's not going to help on price at all. And it's going to remove our ability to utilize the employer's checkbook to control costs and improve quality in next gen plans. If the employer isn't paying for the healthcare anymore, well, then that checkbook is useless when it comes to healthcare. What the administration is saying is they are not going to separate healthcare from the employer. They're going to keep the current system. They're not fixing it, but they are starting to give more tools and more guidance and direction to employers, for instance, around transparency, which is not in the one big beautiful bill, but President Trump has escalated the fines and penalties for failure to provide cost data for hospitals, for instance. So there is a push on the side of transparency, but more importantly, in a conversation I had with Paul Ryan, the former Speaker of the House, it was about a year and a half ago, and I asked him about is Congress going to fix healthcare? And he looked at me. He knew what I do. He knows what I do. He said, Nelson, you're going to have to fix healthcare. Congress is not going to do it. So where does the one big beautiful bill help or hurt? And what other signals are coming out of DC? Well, I said there are two signals, but they're both pointing in the same direction. So policy sets the rules, but culture sets expectations. And those expectations then will drive action in the medium term, if not the short term. So the one big beautiful bill is implementing structural changes. And we'll talk about those in just a moment. MAHA is establishing a cultural reset, an economic reset of how we think about healthcare, how we think about health. And I'll talk about what I saw at the MAHA Summit in just a second. The more important point here is these two changes, these two signals are pointing straight at the employer who's sitting at the intersection of these two signals coming together. So here's the employer, here are the two signals. And it's very, very important to understand that this impacts employers in ways that really nobody has been talking about. But I'm going to do that today. Okay, the first signal, One Big Beautiful Bill. The One Big Beautiful Bill Act that came out of Congress uh, had a lot of other tax implications and other policy implications, but it did have a fair amount of impact on healthcare. So, what changed, and why should employers care about this? Well, the law was signed into effect July 4th. It's a very symbolic gesture on the president's part. He signed it on July 4. In fact, he told Congress, you will have it ready for me by July 4. And they did. And as I said, their tax spending along with the health provisions. The big thing is it rejected any move away from employer-sponsored health care. Half of Americans get their health care through their employer. That would have been a huge, huge disruption had the administration pushed for eliminating the employer subsidy or the employer tax break on offering health care. One big aspect that some people have been talking about, and this goes to the coverage question. Who and what is covering Americans for their health care? Well, as you know, probably know, there was a big, big debate leading up to the passage of the Big Beautiful Bill involving Medicaid and coverage of able-bodied Americans who could go out and get a job, but they didn't, and they sat around on Medicaid. And this was documented. The opposition party made a big, big deal trying to, we're taking healthcare away from people who need it. Well, taking away from people who can go out and get a job and get healthcare on their own, and at the very least get a job and then get subsidized with Medicaid if you're low income. But this was a needed reform, in my opinion. This is commentary here. It was a needed reform, but more important for our discussion today, it forced a lot of people off of Medicaid, which means they are not insured. So that Medicaid and some other public coverage was reduced. Well, that's 10 million or so Americans over time. It's not going to happen. It didn't happen on July 4th. It'd be phased in. But 10 million or more without insurance who are going to start looking for coverage, and some of them may be employed. If they are employed, this may be a migration back onto the health plan of the employer. So that's something to be considered, the impact this is going to have on workforce coverage. So will there be some volatility? Yes, there will be. And this is something that employers need to be aware of, that there's going to be a number of employees, number of Americans who may want to come get a job in order to get covered, but they may be working and they want coverage. So without Medicaid, they'll turn to the employer plan. Okay. So what's the implication here for executives? Well, there's stability in the plan to keep employers sponsoring healthcare for employees. So that's not changing. There's stability there. But that is going to shift a lot of accountability back on the employer because there is no reform coming. There is not going to be any effort to fix the cost of healthcare coming from Washington. So that means that the employer plans are the safety net for anybody who is employable. If they want health care, they are primarily going to be looking towards the employer. Healthcare inflation is not going to be solved out of Washington. It's just not going to happen, which means the employers by default are going to have to deal with this issue. They can gnash their teeth and scream and rend their clothes and pull their hair. It's not going to make any difference. So what should advisors do? How do you as an advisor take the one big beautiful bill and integrate this into the conversations you're having with employers? Because employers don't understand this. They don't know. They may catch a story here or there. There may be something on the news, but a lot of it's alarmist. It's not tactical, and it certainly isn't strategic. So review the impact of the one big beautiful bill in every renewal you've got coming forward. I mean, take the notes from what we're talking about today. I'm going to give you information that you can use. So talk about it. Be the expert on this. And if they ask questions you don't know, simply say, it's a great question. I'm not sure about that. Let me go research it. And then go back and ask Google, ask ChatGPT what the answer to that question is. You don't have to be all-knowing expert, but you're the expert because you bring it to the client and you say, hey, this is important and you need to know about these things. They can affect, especially if in most of the items I'm going to talk about, if they're self-funded, but several items such as 10 million Americans coming off public support, public health care, that affects everybody, every plan, self-funded or fully insured. Take a look at, and you'll need to work with the HR director on this, take a look at their workforce's exposure to cuts in Medicaid. How many employees do they have who may have been on Medicaid while they were working and now no longer have access to it? Because those folks may well turn around and jump on the employer's plan. And this is really important. And this plays into next gen strategies and the next gen operating system, which includes working with the C-suite. Don't just brief HR on this. Go to ask to see the CFO. In fact, tell your HR director, we need to get a meeting with the CFO and make them aware, because some of these issues do have financial implications, not just on the plan, but on the broader impact on the company's finances. For instance, how many employees might move from public plans back onto the employer's plan? Well, that's going to ramp up utilization of the plan, that's going to have a financial impact. So bring the CFO in. It's a wonderful opportunity if you're not already working with the C-suite. Bring the CFO in here and brief him, and it's your opportunity to meet that CFO. What should employers do around the One Big Beautiful Bill and some of its impact, especially around the public reduction in public coverage? So again, assess the workforce exposure to that churn where they're coming out of the public options, public sector plans, and may well jump into the employer's plan. Model the enrollment volatility. What is that going to look like? Do we need to have conversations with the employees that some of you may no longer be eligible for Medicaid? All right, have that conversation with them, and then consider the volatility of claims. Are some of these, what's the age group? What's the gender? What's the set? What's sex? Gender is an artificial construct for grammar. What's the sex makeup? Are there a lot of women who are childbearing years? If they come on the employer's plan and they have a child, that's a substantial financial impact. And that child could, in fact, be premature, go into NICU, onward and onward. So taking a look at claims volatility. And then this goes back to the next gen operating system of working with the C-suite. The employer needs to assign executive ownership of the health plan. Someone with P&L responsibility, someone who owns the profit and loss statement. It's generally going to be the CFO. It might be if they have a CHRO who already owns the P&L, have them own healthcare in a much more proactive way. And you're going to see why as we go through this. All right, there are some tactical upgrades as the result of the One Big Beautiful Bill. These are levers you can use for your employers if they are self-funded. So these are self-funded areas. So first off, the safe harbor for telehealth, telemedicine primarily, but any telehealth has been made permanent. It was passed during the COVID crisis, but it was on a temporary basis and was going to expire. It has now been made permanent. So telehealth, first dollar coverage of telehealth does not affect HSAs. So telehealth and direct primary care both now have safe harbors. They are not considered first dollar coverage in violation of the HSA. So if you do have a HDHP, you can keep telehealth in. More importantly, you can add direct primary care without threatening the HSA. There's also been some expanded flexibility on both HSA and FSA. And well, I'll get to that in a second. So that's another change. These are the three big changes that affect employer health plans. There are some smaller things. I don't have time to get into those. These are the big ones. So you can cover telehealth pre-deductible. Again, it's not considered first dollar coverage. It has been extended permanently. No loss of HSA eligibility. So you can make that telehealth an integral part. You can incentivize it. You want everybody using it to keep them out of the doctor's office, out of the ER, out of the urgent care, unless they need to go to one of those more expensive options. And this applies to all qualified telehealth services, so mental health as well as medical telehealth. So if you are an advisor and you want to do telehealth right now, so you need to confirm that the plan design is compliant with the new regulations. So check that out. If you have questions about that, I'll just give a little plug here for our next gen director of compliance. But if you need to know anything more about that and you don't have legal counsel available, consider calling Loomlight, calling Jen Berman. Used to be MZQ. She got rolled up into Loomlight, Lume Light. So just a little call out to Jen Berman, and her team can make sure that all of the compliance issues are correct. But this allows you to reduce that emergency room and urgent care leakage in the plan by forcefully asserting telehealth to all of the employees to make sure they use it. And now everybody can use it, whether they're on high deductible plan or not. And then be sure to coordinate the plan amendments to address the telehealth utilization. Okay, direct primary care safe harbor. Again, direct primary care no longer violates HSA eligibility. So it's not there are some limitations here, but certain DPC arrangements are permitted. And it's pretty broad, but it is not everything. So you have to be sure that you're working within the constraints of the regulations. There are monthly fee caps. I think it's 150 for an individual employee, 300 for any additional, $300 maximum per month to be spent on direct primary care. So they do have some caps in place. And it defines primary care services, which is very helpful. All right, for the advisors, you now can go to your clients and explain there is no risk to their HSA eligibility for using direct primary care. I know that there was an employer just recently that was holding off hiring a next gen advisor because they didn't want to lose their HSA, but the advisor was bringing DPC as a primary strategy. They loved the DPC, but did not want to lose the health savings accounts. So, as the advisor, you want to validate the fee caps, make sure that your employer clients using DPC are within those financial caps for monthly fees. You need to look at the covered services, make sure that they conform with the regulatory list of services that are allowed under DPC and in this new regulation. And then be sure to align DPC with your claims strategy. How are you using DPC to control not just the primary care, but also downstream claims, which is critical. One of the key, most central values of a direct primary care physician is serving as a gatekeeper or a funnel, if you will, to make sure that employees go to the highest quality providers downstream. So the specialists, the surgeons, et cetera, the diagnostic testing centers, et cetera, in order to make sure you're providing the highest quality care, which then will, of course, lower the price. For those of you who are not familiar, there is a price quality paradox in healthcare. And if you want lower cost, go to higher quality care, and it almost always drives the cost down. But the DPC is your opportunity to make sure that those employees are getting channeled, guided to those high quality providers. So be sure to align claim strategy with your DPC. All right, HSA and FSA enhancements. Again, more flexibility. Bronze and catastrophic plans are now eligible for health savings accounts. Brand new, completely out of the blue. So that's available. The dependent care FSA limit has been increased up to $7,500. but plan amendments are required to implement these. So be sure to look into the compliance aspects there. For employers around this, what actions do you need to take? Well, here's a quick execution checklist. Decide which provisions you want to adopt. Are you going to do a big push on telehealth and roll it out to all the employees, even those who have HSAs? Is that an initiative? Is DPC something you want to adopt now that it does not interfere with HSA eligibility? FSA, where do you see the opportunities to use these as retention tools? Because these are retention tools. These are different and have value that not every other employer is going to be offering. So which ones? Be sure the plan documents are amended. You can work with your advisor on that. And then don't forget to communicate clearly to the employees the changes. It doesn't do any good to offer direct primary care if the employees don't understand why it's so much better for them. The same with telehealth, the same with the FSA. If they don't use it, it has no value. So the communication piece is essential here. And again, if you're an employer on this today, be sure to work with your advisor on that. None of this falls to you directly. It's just the oversight and the executive guidance and direction that you want to provide. So policy changes the tools you can use. So all of a sudden, direct primary care is a tool available even in high deductible health plans without impacting the HSA eligibility. But culture changes expectations. So let me go back to this real quick. The rules are changed by the law. So the one big beautiful bill is changing the rules on you. And you need to make sure you're taking advantage of those rule changes and that your clients understand those rule changes. Again, be the expert. But MAHA changes the definition of the problem you're dealing with healthcare. First of all, let's remember it's not a healthcare system in the United States, it's a sick care system. MAHA speaks to that, and I'll talk about that in just a second. The problem isn't just providing access to care. It's improving the quality of the care, but it's also looking at why does the employee need the care. So the first signal that we were talking about coming out of DC, two signals. The first signal was the one big beautiful bill. The second signal really gelled a couple of weeks ago in DC, the Waldorf Astoria Hotel for the official 2025 MAHA Summit. It really wasn't the summit per se, but the summit crystallized a lot of the thinking and formalized a lot of the thinking coming out of the MAHA movement. This is the second MAHA event I've been to this year. In May, I went to the inaugural MAHA roundtable put on by the new MAHA Institute. This was pure policy. It was extremely in-depth from 9 in the morning until 7 at night. We heard from policy and active policy people and activists all day long on a broad range of topics. The MAHA Summit was much more formal, much more professional, and it was designed to send a signal to official Washington that MAHA is part of the structure now, that MAHA itself is official. And if you have any question about that, just remember who's running healthcare in this country for the next 2.5, 3 years, how much longer we have in the Trump administration. For sure. You've got Bobby Kennedy, RFK Jr., as your Secretary of Health and Human Services. But you also have Dr. Oz, You've got Jay Bhattacharya at NIH, National Institutes for Health, and you've got Marty McCary at FDA. And all of them are on board with the MAHA agenda. I heard it, I've seen it, I've heard about it. There's no question. MAHA is the operating system for the Trump administration's healthcare initiatives, whether it's on drugs, whether it's on research, whether it's on healthcare programs like Medicare, Medicaid, et cetera. MAHA is operational. So let's talk about the summit. This was a day-long event. As I said, had to stand in line to go through security with the Secret Service because not only was Secretary Kennedy there, so was Vice President J.D. Vance. The two of them, about midday, came together on stage for a fireside chat, which was extremely open and extremely raw. In fact, at one point, and he made the news on this because it leaked out, Vice President Vance called bullshit. I'm quoting the vice president, so don't send me an email or text telling me. He called BS on Secretary Kennedy's critics, accusing him of having views that were out of the medical mainstream. When Vice President Vance noted that the current scientific establishment's unwilling to challenge orthodoxy, and pointed out that convention is often wrong, and the people who make advances in science are almost 100% of the time people who are willing to challenge orthodoxies and advance heterodoxies and talk about new ways of thinking. It was extremely compelling because the Earth is flat, and yet Copernicus said no, it's not. And back in the day, you could be put to death for outside of the orthodoxy thinking. Secretary Kennedy pointed out that above the doorway of the Royal Society in London, the Royal Society being the premier scientific institution in the world, above the doorway is engraved in the lintel to question everything. Question everything. And this administration wants to question everything. Marty McCary actually pointed out that if this administration is wrong for thinking outside of the orthodox medical community's mindset, Marty pointed out that we've been telling parents not to feed their children peanut butter until the age of 3 in order to prevent peanut allergies. He then said that's exactly what causes peanut allergies, not having access to it when you're young enough to develop an immunity to those allergies. The orthodoxy was wrong. That hormone replacement treatment for women going through menopause was named as a carcinogen, and literal black labels were put on the boxes to discourage women from using it. They didn't outright ban it, but they strongly discouraged, calling it carcinogenic. It's not carcinogenic. This administration is taking those black labels off the boxes. And so there's just a lot of examples that Marty gave of orthodoxy that's just not legit. Okay. The MAHA Summit. MAHA is going beyond politics. Bobby Kennedy ran for president on this MAHA agenda because it made it a political statement, a political plank, if you will. It's moved beyond politics into policy. So why should employers pay attention to what happened at the MAHA Summit and pay attention to what's going on in the MAHA movement? Make America healthy again. So first of all, MAHA and at the summit, uh, there was a focus on chronic disease. Look, Americans use so much health care because Americans are sick. It's a sick care system. There are a lot of Americans with diabetes, high blood pressure, other chronic diseases that start somewhere. People don't just get chronic diseases out of the blue for no particular reason. So this administration is focusing on those chronic diseases and the causes of those diseases. As part of that, they're elevating food, nutrition, and prevention as a frontline defense. Well, our type 2 diabetics diabetic because it's in their genes or because it's in their food, because they're drinking sugar water, soft drinks, because they're eating food that is high in sugar content and high processed, overly processed foods. And then health is being framed as an economic issue by the MAHA movement. We heard it over and over again at the summit. Health is an economic issue. It's not just a health issue because it has such profound economic impacts. All right. This is where it starts to impact employers. MAHA is looking at the upstream drivers of health, or actually drivers of unhealth, dis-ease, chronic conditions, ultra-processed foods. One of the speakers on a food as medicine panel was Scott Morris, the senior vice president for food and consumables at Walmart. And he was there to talk about ingredient transparency, that we want people to look at the labels, but they're getting pressure because people are looking at the labels. And Mr. Morris announced the removal of a long list of additives from Walmart's private label food products. So where they have control, they're acting to eliminate a lot of additives that are considered to be dangerous and that contribute to health problems. Metabolic disease was emphasized, and this goes to a lot of different aspects, both food, exercise, movement, etc. Over medicalization. Marty McCary talked about this, that everything is medicalized, and there's too much of that. You know, some things like we're talking about, like mental health. I'm depressed. Well, you're depressed because you're grieving because you just had a death in the family. I need some medicine for it. Well, the patient may not say that, but the doctor will say it. Here, take an antidepressant. Well, then you're masking the emotions that are legitimate because they come from grief. There's a lot of over treatment, over medicalizing emotions, feelings that are natural, but we're giving people drugs for that. There's also over medicalization of physical conditions as well, where there is misdiagnosis in terms of, yes, you need a stent, where 60% of stents are unnecessary. So over medicalization in that sense. And then finally, there was an emphasis on mental health and stress and its impact on health. So these are all areas that, as you can see, employers can address. Very interesting. There was a lot of agreement at the MAHA Summit, but there was one particular point of contention, and it was a flashpoint, and I think you're going to see more of it. And that's on GLP-1s, Wegovy, Ozempic, et cetera, et cetera. MAHA is, and it flows from Bobby Kennedy, Secretary Kennedy, is very, very hostile to the drug companies. Not every drug, but many of the drugs, and the mentality of, oh, let's give a drug for that, instead of treating the root cause, which is the second point. The drug companies want to medicate, here's a drug for that. The doctors say, oh, just take this drug. Well, the drug treats the symptom, but it doesn't treat the root cause. And if someone is diabetic because of their diet, putting them on GLP-1s isn't necessarily going to help if they don't change their diet. In fact, there was a little bit of a brouhaha over a company that does nutrition uh, coaching. And the owner of the company said, my father went on a GLP-1, so we're providing him coaching around his use of the GLP-1, nutrition coaching and behavior modification coaching. And another panelist said, why are you validating a GLP-1 that way? So there's this conflict going on. And of course, on November 6th, President Trump announced that he had negotiated massive discounts with the two drug companies, Lilly and I forget the other one, on Ozempic and Wegovy down to $350 a month. And Dr. Oz announced that in March, this was at the summit, announced in March that in March, an oral pill should be approved by the FDA and available for uh, public public use consumption at $50 a month. $50 a pill, I assume it's one a month. So there's a lot of issues here, and given if you've got a self-funded client, you know the problems with GLP-1s. They're expensive, and there are a lot of people who are overweight that want to use them. There are a lot of diabetics who want to use them and who rightfully can use them. But this is a flashpoint, serious flashpoint. All right, so if you're the advisor, how do you translate MAHA into plan strategy? So first, I'm going to recommend you look at implementing a population health management strategy for your self-funded employers. You can't know what's going to happen to employees who haven't been to a doctor in 10 years. There are no claims data. And for them, you can't do predictive analytics for a patient, an employee who doesn't have any claims data. But with biometric testing and with HRAs, health risk assessments, you can find out, oh, wait, he has a family history. She has a family history. Oh my gosh, his A1C is off the chart. His blood pressure is off the chart. You can get that information with a good population health management strategy. Ben Connor, who's in our mastermind group, uses this in his biggest clients to make sure that he's got eyeballs, that windshield isn't covered with newspaper, so that he can see what's coming and can intervene with those employees who are trending towards diabetes, a massive heart attack, a stroke, cancer, whatever. They can get ahead of it and actually manage it. So first, I would recommend you implement a population health management program. Number two, focus on metabolic health. Now, I don't have time to go into how you do that, but there are plenty of resources available to find out what can you do within the employee population to encourage better metabolic health. Strengthen primary care access. Now, here's where MAHA and One Big Beautiful Bill definitely come together. What's the best way to strengthen primary care access? Direct primary care. Paid for by the employer, 100% free to the employee, all the primary care they need at no out of pocket. There's no financial resistance to going and getting that primary care in a DPC environment. The same with telehealth. It's easy and no cost. Direct primary care is just far superior, but advanced primary care, however it's delivered. And then finally, demand health outcomes from your vendors. Don't look at KPIs that aren't meaningful. Look at KPIs that matter. Like, are the employees getting better? Again, I'll bring up Ben Connor. They're doing an intervention with diabetic employees at one of his large clients, and they're insisting that the vendors reduce the A1C? They are. They're getting results from the program. The money is being well spent. So you want to hold those vendors strictly responsible for outcomes. All right, for employers, uh, this is about choosing a priority. You can't do multiple things at one time very well. Choose one priority and then measure it. If you don't measure it, you can't manage it, uh, uh, said a brilliant market management expert back in the day. So, access to better nutrition. If your company offers a cafeteria or vending machines, make sure that they are providing better choices for the employees. Will the employees like it? No, of course not. They want their Coca-Cola and Twinkie, but that's not the responsible thing for the employee to do. If they want the Twinkie, they got to go across the street to the convenience store and get it there, and hope they don't get hit crossing the street. Second is maybe redesigning primary care, looking at maybe direct primary care through telemedicine, a virtual option, or direct primary care, brick and mortar in the neighborhood. But taking a look at redesigning that primary care program for employees. Another option that got a lot of conversation is sleep and stress. This is a huge contributor. Lack of sleep and lots of stress, a huge contributor to health problems that end up being treated in our sick care system, which impacts the healthcare spend. So those are three areas where an employer can exercise disciplined experimentation. Right? Let's pick one and work there. And again, to the employers in the audience, work with your advisor on this. And if your advisor goes, I don't know how to help, find an advisor who does. All right. So the combined signal that we're talking about here, public coverage for healthcare is shrinking while expectations are rising. So you're getting more pressure from uninsured employees probably coming on the plan. At the same time, there's a higher burden from chronic diseases. They're continuing to increase. The incidence of cancer is down. Marty McCary pointed out, but the severity of cancer, the severity of cancer is down. We're treating it better, but the incidence is up. More and more people are getting cancer. What's that about? Where's that coming from? Same with autism. 1 in 34 20 years ago, 1 in 34, one in 150 children 20 years ago. Today it's 1 in 36 children are autistic. Where's that coming from? What's causing it? What are the root causes? And with these signals here, uninsured pressure, chronic disease burden, the employer is in the middle, again, at that intersection. So here's why proactive employers have an advantage, because control beats doing nothing. Sitting there doesn't do you any good and will cause you as an employer to fall behind. Self-funded plans offer control in the right hands with the right advisor. You can't do it if the BUCA carrier is your administrator. You've got to have an independent third-party administrator. But self-funded with an independent TPA, you've got control of the plan and visibility into claims data. You can do the population health management, get visibility into the population and who is not driving the cost today, who's going to drive the cost tomorrow? And can you intervene? And in many cases, yes, you can. Transparent vendors do better. Why? Because the reason they're transparent is they know they produce results. Opaque vendors are hiding something. What they're hiding is lack of production, lack of performance. And then finally, for proactive employers, early movers, first to market, have an advantage in terms of retention, in terms of recruitment. Here are the things we're doing to provide our employees with better health, not better health care, better health, and better health care when you need to have health care. But it's not, most employees aren't sick and they aren't using the healthcare system or the sick care system. When you're addressing employees' health, you're addressing every employee. And that will attract employees who care about that, who want to be healthy. And healthy employees are more productive employees. All right, advisor action. I'm calling this the Washington Signal scorecard, but uh, keep track of what levers in the big, beautiful bill are being implemented in your client's health plan. What MAHA priorities are you addressing in the health plan? Now, of course, you want to track it. If we are doing something around health, promoting, let's say, sleep, find a way to measure that. Do surveys, do focus groups within the employee population, and then document the governance. As the employer starts to take control of the plan, make note of that. Where are we stepping up and taking control? And what impact is it having on the quality, on the outcomes, the quality of care, the outcomes of the care, and the cost? Because when you can measure that, you can manage it, but you can also show your client. Employer action. This is about governance, not just administration. HR administers the plan. The C-suite can govern the plan, not run it. That's administering it, governing the plan. So writing down rationales for making these decisions. We're going to do direct primary care because we don't think enough of our employees are getting care early on. And we want to remove the financial restrictions, and we want to provide higher quality care. So writing those things down, defining what success looks like, and then measuring it. And then a quarterly executive review with your advisor, but with the CEO, the CFO, and HR, reviewing the results on a quarterly basis to see if you're making progress. So I'm going to recommend a 60-day employer playbook. This is what to do next. Review your telehealth and DPC. Are you doing either one? Which one? And if you are doing one of them, which one? And what are you doing about it? How are you going to do it? Are you implementing the FSA and HSA changes? And then try one MAHA aligned program. Pilot it. Do it with a small group of employees, but pick something that is out of the MAHA playbook and implement it in your playbook. Final thought. This is not about politics. I know it comes out of politics, but it's not about politics. It's about leadership, because healthcare is going to change. It's changing now. The question is, who leads the change? And the question is that leader at a competitive company that can hire your people away? Or are you leading? Because doing nothing is a choice. Doing nothing is an active choice. Passivity is an option. It's just not a very good one in this instance. So that's how the One Big Beautiful Bill and the MAHA movement, particularly the MAHA Summit, crystallizing MAHA as a movement in DC that is impacting the healthcare agenda of the Trump administration, comes together. This is how it works together. If you're interested in learning more about these initiatives and more, I encourage you, join us in January in Nashville. I'm in Nashville today. Join us in Nashville for the 11th annual Ascend Conference. Our theme this year is Beyond the Healthcare Twilight Zone, because when you spend any time in healthcare, you have to believe you are in the twilight zone. It's not logical. It's not consistent. It's not sensible. It's it's surreal. So we're going to show you how to get out of the healthcare twilight zone. We're going to be talking about consultative selling, selling into the C-suite, selling self-funding, and managing the healthcare supply chain. And a lot of the One Big Beautiful Bill, and especially MAHA, is going to be wrapped up into that. So I hope you'll join us in Nashville, January 27th through the 30th. If you want to learn more or register, attendascend.com. Thanks for joining me at the Healthcare Lounge. If I don't speak to you personally before the new year, Merry Christmas, Happy Hanukkah, and Happy New Year. Be safe. Happy holidays, everybody.